Welcome to Pediatric Cardiology, Part 3, Kawasaki's disease. There are 2 videos about this disorder already recorded by Khan Academy, so be sure and watch those. Kawasaki's disease is a vasculitis type of disorder, and a vasculitis means inflammation of all of the blood vessels. When you look at this child on the left, you can tell that he isn't feeling very well. What I like about the picture is it really gives you a good look at what Kawasaki's is going to look like on your patient. The child has a fever that lasts more than 5 days. And because of that, they're also not feeling well, they're not cooperative, they're crying, they're cranky. They have a conjunctivitis, but what's different about this type of conjunctivitis is it isn't bacterial. And when you look at this child's eyes, you can see that they're a little bit puffy, and there's erythema, especially on the lower lids, and when you look at the drainage, it's clear. Look at this child's mouth. There are 2 things that you should notice. The first is the red tongue. And this can be described as that strawberry tongue. But also, when you look at his lips, you notice how dry and cracked and peeling they are. He has his hands up to his face because whoever was taking the picture wanted you to see how Kawasaki's affects the skin. If you look closely, you can see that this skin is peeling, and we call that desquamation. So his mouth and his fingers are desquamating. If we were to palpate his neck, we would also feel enlarged lymph nodes. Notice also that there's a little bit of swelling of this little guy's fingers. And if we were to turn his hands over and look at the palm of the hands and the soles of the feet, we would see that it's erythematous because of a rash. This child will also be tachycardic. In the second phase of Kawasaki's disease, which begins about day 11 and lasts another 2 weeks, is the highest risk of them developing the coronary aneurysm. So remember, vasculitis, inflammation that is systemic, including the coronary arteries and the coronary vasculature. There's a very high risk of developing clots. There's weakness of the vessel walls that causes the aneurysm. So initially, when this kid is in the hospital, because by now they are, we're going to send him for an echocardiogram. Now, once again, you can see on the picture here what these kids look like with the swollen lips, the conjunctivitis that is non-bacterial, and the strawberry tongue. This child will be followed by cardiology upon discharge, which happens after the echo and after we infuse treatment. They'll be seeing cardiology at 2 weeks, 6 to 8 weeks, and about every 6 to 12 months, depending on the results of the echo. If the echo is negative at 2 weeks and again at 6 to 8 weeks, this child is probably in the clear. If there is an aneurysm present, this child needs to be started on high-dose aspirin and will use aspirin for the rest of their life because they continue to have that increased risk of developing a thrombus. During the second phase of Kawasaki's is when full desquamation begins. They're still irritable and they don't want to be eating anything, so you'll be administering IV fluids until they'll tolerate POs. In the third phase of the illness, they have the convalescent period. So gradually, the temperature is going down, the skin is no longer peeling, the sed rate and the CRP levels are going to return to a normal range, and they have what we call the Bose line, and that's what this line is across this child's thumb. So your nursing care, fever and comfort measures. This kid does not feel good. They are very irritable. They are going to fight you with everything because they do not want you to disturb them. We're going to give them IV fluids if they cannot tolerate or if they just won't cooperate and take orals. Give them plenty of rest, and this child is not going to be able to go to the playroom. And then what's different about this is you will be giving high-dose IV immunoglobulins. So we give 2 grams per kilo, and it is infused over a 10 to 12 hour period. You need to monitor the vital signs, especially the blood pressure, every 15 minutes for the first hour, and then every 30 minutes until fully infused. So when you see that this is going to take place over 10 to 12 hours, this child is going to take a lot of your time, and so your patient load will not be the typical 5 to 1. It may be 1 to 1 or 2 to 1. Monitor for anaphylactic reactions. In addition, you'll be administering aspirin. And yes, we do still worry about Reye's syndrome, but in this case, the benefit of the aspirin outweighs the risk. So this child will begin on 80 to 100 milligrams per kilogram per day. And then once cardiology says that they're okay, they're going to decrease the dose down to a 3 to 5 milligram per kilo per day maintenance dose that they'll take throughout their life. And this ends Kawasaki's disease.